Good evening to everyone present here with us today. This is Rion from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Vijay Varad. Sir is MBBS, MD, consultant allergist, pediatric pulmonologist, clinical immunologist, and consultant at Sai Allergy Asthma Eye Hospital. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is upper respiratory infection. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thanks, Rion, for your introduction. Thanks to IJCP for sharing the platform to discuss about the clinical scenarios into the community so that the practitioners should have a benefit and the community should have a benefit of it. So, like recently, I think many of you must have been found that a lot of people are having a problems and continuously the cough, which is not going away, and along with that, recently last 15 days to 1 month, we are seeing an upsurge in upper respiratory infections, sinusitis, and throat problems. So, what are these upper respiratory infections? Why some or the other seasons during the rainy season, maybe during the winter, then after having ice cream or cold drinks or change into the oils or after the dust exposure, why they have this problem? And so we'll go to the basic practical ways. So they range from common cold, typically mild, self-limited, with symptoms from the nose or pharynx, to life-threatening illnesses such as the epiglottitis, and where the choke-up happens, the patient has a significant difficulty in breathing stridor. You can hear the sound from far away also. And most of the viruses account for these upper respiratory infection. And diagnostic tests for specific agents are helpful when targeted treatment for that. So depending on the investigations we can. So what are the clinical presentations? Commonly, the rhinitis, which where the nose mucosa is involved, then laryngotracheotis, where inflammation of the larynx, the upper airway, or trachea or subglottic area is there. Some of the patients has a significant epiglottitis. Pharyngitis is a very common. Most of the patients have a throat infection, and where the hypopharynx, uvula, and tonsils can be involved. Even the smaller children's, the adenoids are also involved into that. Then tracheitis, then epiglottitis, which is very severe, and where because epiglottis covers a very smaller area where there is a narrowing of the airway, and if it is swollen, the patient is unable to breathe also. And even suppose the coin or some foreign body is stuck up over there, how it has so much difficulty and it becomes an emergency. And then nasopharyngitis, where the inflammation of the nares, pharynx, hypopharynx, and adenoids, tonsils can be there. In pathophysiology, basically this is a direct invasion of the mucosa lining the upper airway. The inoculation of bacteria or viruses occurs when a person's hand comes in contact with the pathogens, or through the sneezing by somebody else or coughing, it travels from one person to another around 3 meters. Again, the adenoids and tonsils contain the immune cells that respond to these pathogens, and this inflammation causes the problems. Humoral immunity, immunoglobulin A, and cellular immunity act to reduce the infections throughout the entire respiratory tract. A host of inflammatory cytokines mediates the immune response to invading pathogens. Patients with suboptimal humoral and phagocytic immune function are at increased risk for contacting a URI. They are at increased risk for a severe or prolonged course of disease. So, wherever there is an immune dysfunction, hypoimmunity, or underlying some chronic diseases like HIV or anything, primary immunodeficiency, combined immunodeficiency syndromes, they are very rare. But nowadays, there is a documented data that amongst the upper respiratory infections, throat, tonsil, adenoids, the Th2 inflammation plays a very important role. And in this Th2 inflammation, the allergy has been a very important. So again, the acute or chronic allergy is a chronic inflammation, and it predisposes to the secondary upper respiratory infections. And as we said, suppose some person is having an infection, you will sneeze or you will clean with some cloth and all, then it spreads. Then again, the tables and desks where the heat touches that person. And most of the time, the viral infections with the different serotypes. And then the frequency in the changes in the antigenicity posing challenges to the immune defense. Most of the symptoms are localized swelling, erythema, edema, secretions, and fever. So infection means most of the time fever. The rest of the other things because of the secretions, they have that. And this can spread from most of the they are from nose, and then it can spread to sinuses, one mucosa, one disease, then otitis to the through the eustachian tube, epiglottitis, laryngitis, tracheobronchitis. And when it increases and some distal part of the lungs, then pneumonia can be there, or severe bronchitis leading to the bacterial protracted bacterial bronchitis or something. And genetic susceptibility is very important. Then the severity depends on that. Again, the gene polymorphisms, known as the functional changes in the genes that will lead to the immunosuppression. And it has also been seen that most immunogenic variations plays a role in the immune response to H1N1, H5N1 viruses like COVID viruses. Also, we saw that those are type of influenza, parainfluenza, respiratory syncytial viruses, pneumococcal, like there are different type of pneumococcal 13 valent, 25 valent vaccines also available nowadays to prevent that. So most of them are viral, but 10 to 20% can be bacterial also. So which are the commonest viruses? Rhinoviruses, coronaviruses, adenoviruses, Coxsackie viruses. Nasopharyngitis, around 200 types of viruses have been found which cause the common cold. Like so, rhinoviruses again 30 to 50% of the colds in adults, and depending on the temperature, they grow in that. Then coronaviruses recently we have found that then enteroviruses, including the Coxsackie viruses, ecoviruses, and other one. Other viruses that account for many URIs include the following, like adenoviruses, orthomyxoviruses, paramyxoviruses, RSV, EBV, human metapneumoviruses, and bocaviruses. Even now, RSV, I'm doing a clinical trial for that. The patients with COPD, asthma, which have very severe infections, the vaccine will be coming recently. Bacterial causes of pharyngitis include the following, like group A streptococcal, very common, group C and G streptococci, Neisseria gonorrhoeae, Archaeanobacterium, Corynebacterium diphtheria, a typical mycoplasma and all chlamydia, anaerobic bacteria are rare. Rhinosinusitis in an immunocompetent person is typically related to the uncomplicated viral URI. Viral causes are similar to those of the viral nasopharyngitis and include the following, the same one, what we discussed above. So most of the influenza A and B is very common and which are covered under the influenza vaccines also. And adenovirus. We have seen like recently when there was a rhinoconjunctivitis going on. This adenovirus was a very important. And again, during the summer now, as the swimming starts, these adenoviral infections increase a lot. And a lot of people have rhinoconjunctivitis also. As we discussed, the bacterial causes Streptococcus pneumoniae, 38% of the adults, 21 to 33% children. Haemophilus influenza, 36% in adults, 31 to 32% children. Moraxella catarrhalis, 16% in adults, 8 to 11% in children. Staphylococcus aureus, 13% in adults and 1% in children. And other pathogens like group A streptococci and other streptococcal species, Aspergillus species are the leading causes of non-invasive fungal sinusitis also. Even this Aspergillus, which gets secondarily contaminated into the pigeon droppings. In Pune, we found 37% of the people have this Aspergillus, which is contaminated into the pigeon droppings. Epiglottitis, in the vast majority of the children, H influenza type B is isolated from the blood or epiglottal cultures. The prevalence of non-invasive hip disease is approximately 1.3 cases per 100,000 children. And rates in adults have been remained low and stable. Laryngitis and laryngotracheal bronchitis, worldwide, pertussis is very important. In between, again, the upsurge was there. That's why MMR vaccination had been given. Other hand, challenges in the laboratory diagnosis and over-reliance on the polymer chain reaction have resulted in reports of respiratory illnesses outbreaks mistakenly attributed to the pertussis. Occurrence rate of selected pathogens, group A streptococci bacteria 5 to 15%, childhood Epstein-Barr viral infections approximately 35 to 50% of the adolescents, young adults who contract the EBV infection have mononucleosis. Again, seasonality is very important. You can see here, like March to May rhinovirus. And depending on that, this chart is available everywhere. So you can decide about that, which are the common clinically. Then again, race and sex related demographics are there. So most of the patient, common cold like presentation will be there. Fever can be there, headache, body ache. Then along with that, some of the patient have a diarrhea also. And significant stridor or croup, then epiglottitis or laryngotracheal bronchitis. Then according to the age related demographics are there. And basically these URI are a gateway to the other structures leading to the otitis, bronchitis, bronchiolitis, pneumonia, sepsis. Very severe cases, the patient can have a significant meningitis, intracranial abscesses. And these are the complications. Nasopharyngitis, most of the patient within 7 to 14 days they recover it. But if persists, then it leads to the sinusitis or bacterial bronchitis, which may require 4 to 6 weeks of antibiotics. Then again, pharyngitis, viral pharyngitis typically resolves in 1 to 2 weeks, but immunocompromised persons like rheumatic fever, toxic shock syndrome, otitis, acute glomerulonephritis, impetigo, sinusitis, peritonsillar abscess, cellulitis or abscess, conjunctivitis. Rhinosinusitis, it can have orbital cellulitis, subperiosteal abscess, orbital abscesses, frontal and maxillary osteomyelitis, subdural abscesses, meningitis, brain abscesses. Epiglottitis, as I mentioned, in acute cases, it can have a very severe prognosis, and if it not treated properly, it will land up to the complications. Laryngotracheoitis and all, the sound is so loud and groups like they again stage 1, stage 2, stage 3. Sometimes we have to give adrenaline nebulization also or oral and parenteral steroids. Most of the patients with URI, they resolve with the symptomatic management or some specific antibiotics and all, but many of them may go into the low respiratory infections, encephalitis, meningitis and all. So it should not also be neglected. And again, if it's sepsis, then depending on that, different metabolic problems like hypoglycemia, hyperglycemia. And these complications of the specific conditions, depending on that, like pertussis specifically, apnea, pneumonia, seizures, encephalopathy, and it can lead to the mortality also. Complications of influenza, encephalitis, meningitis, pneumonias, then dehydrations, renal failures, rhabdomyolysis, and all. Viral nasopharyngitis, generally common cold, 2 to 3 days, it can be there. Nasal, like cold, runny, or if there is underlying allergy, blocking can be there, sneezing, headache, throat pain, or halitosis, difficulty in swallowing. Other manifestations, foul breath, hyposmia, headache, sinus symptoms, photophobia or conjunctivitis if it is severe, unable to look at the light or intense sunlight. Fever, if it is high grade, then patient can have febrile convulsions also. Then gastrointestinal symptoms with nausea, vomiting, diarrhea, severe myalgia, fatigueness. Patient requires a rest for that. Hydration should be maintained properly. Then pharyngeal symptoms, throat pain, nasal obstruction can be there. Fever, if it increases, then again, it leads to the different type of any viral-like illnesses. And there are many with other manifestations. So, like some of the patients who can have a viral rash also, abdominal pain and all. There are studies done like persistent nasal discharge with cough lasting more than 20 days. Then can be bacterial bronchitis or bacterial sinusitis. And if it is a very high grade fever lasting more than 3 days, then we have to always investigate that with the complete blood count or nasal discharge, if it is mucopurulent or serosanguinous. Then, depending on the sinusitis, check for the sinuses and all, treat it for 8 to 10 days. If it is otitis, then depending on the post-auricular Some patients may require 14 days also antibiotic. And the dry mouth can be because of the sore throat. Cough, if it is a irritating specific cough, once postnasal dribbling, if it is patient just lies down and he has that trigger and headache, and if there is a significant sinusitis pressing on that, it will have anosmia or hyposmia. Then excessive salivation, drooling of the saliva, dysphonia, irritating cough, sniffing posture, facial grimaces. Laryngotracheoitis and bronchitis, significant lower airway involvement can be there, or group like then lump in the throat with a posterior pharyngeal abscess or something. We have to find it out depending on the X-ray and all. Fatigue is very common in these patients. Weakness, dehydration can be there in smaller children or adults basically. And whooping cough, typically the child or the adults, adolescents try to bring it out, and it has a very significant whooping like things are there. While examination these patients, always check for the nose, throat, ears, temperature also. Then depending on the what type of viruses, we have to treat the patient accordingly. Suppose conjunctivitis is there. Proper care of the eyes, cleaning of the eyes are very important. And if the tonsils are enlarged, open mouth breathing adenoids can be there. Bacterial pharyngitis and all, the significant temperature will be very high. Streptococci and all, there can be a typical red magenta tongue or throat, posterior pharyngeal hyperplasia can be acute with the congestion of that. And if there is a rash and all, then look for the what type of infection is can be there. Then exudates and all, the foul smell, mucopurulent, depending on that, the patient may require a proper antibiotics. Typical rhinitis, most of the patients have rhinorrhea, but if the underlying allergy and all, that can be a more blocking or sinusitis, which will have a. Then periorbital swelling can be present in ethmoidal sinusitis. Then sinus tenderness can be there. Very severe patients, if there is an intracranial suppurative complications, then proptosis, decrease vision, changes in the mental status, neurological finding can be there. So most of the patients, there is a dry irritating cough. And if it goes down, then they will have a wet cough. So while differential diagnosis is also very important, if it is a repeated one episodes, then allergy can be the underlying thing. The asthma can also be triggered by that. Community acquired pneumonia, very severe infections where there are multiple system or abscesses are there, then IgA abscesses, depending on the viruses, then obstructive sleep apnea, adenoids, tonsillar hypertrophy, otitis. Along with some of the patients will have a reflux laryngitis also. And then then while diagnosing, the nasopharyngeal sampling can be there, cultures, rapid tests, viruses, then blood counts and cultures also can be done depending on the patient's response. If the patient is not responding properly, then we have to think about which antibiotics to be there. Then some of the patients, the like specifically posterior pharyngeal abscess and all, the lateral X-ray can also be done. And suppose the cough is not going away and high-grade fever, then X-ray chest also can be done. Rhinosinusitis, depending on that, CT scan also can be done. Nowadays, anterior rhinoscopy is also a very good option. Then some of the patient, while treating, the puncture also can be done. In rare cases, the rigid nasal endoscopy can be put and then the culture can be done for that. Suspected influenza, specifically rainy seasons and all, or winter sometimes, depending on that, antiviral medications can be given. If it is a mononucleosis, accordingly, we have to treat that. We can go for the neutrophil antibody test as a diagnosis. In cases of herpes simplex viral infections and all, the mucocutaneous lesions will be there. Their cytologic detection of cellular changes of HSV infection, and then testing with the PCR technology can also be. In suspected pertussis, we know the swab to be taken and examined under the PCR. Then, if it is epiglottitis, we have to investigate for the proper blood cultures for the H influenza. And as I mentioned about the lateral neck X-ray in case of epiglottitis and posterior pharyngeal abscess. While treating the patients symptomatically, most of the patients with a proper steam or the nasal douching along with anti-fever medications, anti-cold preparation when it is required, and some of the patients where specific viral like flu-like infections, if it is very high-grade fever, then anti-flu medicines, and when there is a bacterial, then go for the specific antibiotics. So, in an antibiotic therapy, generally after 2 to 3 days, and in very severe cases of streptococci, where significant high-grade fever and there are specific signs of streptococcal infection clinically, or otitis or sinusitis, then only the antibiotic should be started early. Then, depending on the laryngotracheitis, like croup-like things, the nebulization also can be given with adrenaline nebulization, and depending on that, humidified oxygen should be given to these patients. In very severe cases of croup and all, the intramuscular or intravenous steroids also can be given. The dehydration should be properly maintained, and hydration should be maintained properly. Rhinosinusitis, if it is required, then more than 7 days course should be given in otitis and sinusitis of antibiotics. Again, there are different type of guidelines accordingly. In cases of there are hidden signs of allergy like dark circles, wrinkling, denim organ folds, or rubbing of the nose causing the derriere line and cervical lymphadenopathy and significant family history. Then nasal steroids can be given depending on the season. And group A streptococcal diseases, amoxicillin, amoxiclavuline combination can be used for 5 to 10 days depending on the sinusitis or not. Then some of the patients first generation anti-stem cephalosporins can also be given in cases of penicillin or amoxicillin allergy. Or patients can be given a clarithromycin or azithromycin depending on the situation. In general, relapse of group A streptococcal disease may be treated with the same regime as before with a different one. And suppose there is a relapse, depending on that, we have to investigate the case, again assess the diagnosis and treat the cause of that. Then very rarely the herpetic or gonococcal pharyngitis can be there. There we have to give a specific antivirals like a cyclovir or those things. Patients with the immunocompromised things, then it requires a lot of investigations. We have to go for that, and then we have to treat with the specific antiviral drug. Surgery is rarely indicated where very few people, specifically adolescents and all, then depending on that, we have to uh, do with the interference of that. Self-care, warm, moist air, nasal saline, hydration, warm facial packs, or in smaller children, the bulb suction can be used. Nasal irritants like specific smokes, passive smoking, indoor and outdoor pollutants, and avoidance measures has to be aware about that. And then the steam inhalation can also be given in some of the patients. Then symptomatic and pharmacological therapies, oral or topical decongestants, ipratopamine bromide, antihistamines. The safer one should be preferred rather than the sedative one. If required, then the topical nasal steroids or oral or parenteral steroids, saline nasal drops, then topical phenyl or lidocaine, bromelain, sodium. Ipratopamine bromide, antihistaminics like pexofenadine, desloratadine, then bilastine is a very good anti-inflammatory. Saline douching nasal wash are available for the adults also, and then steam inhalation depending on the blocked nose or sinusitis. Cough relief, when there is a specifically upper airway irritating cough, then decongestants can be used as a brompheniramine, diphenhydramine, or pseudoephedrine. Then post-infectious cough, if it is reverse severe and it is leading to the GRD also or induce that, then the anti-reflux medications also can be given in these cases. Several agents like codeine, guaifenesin, dextromethorphan are intended for the symptomatic relief of cough. Codeine has been in very few cases. Most of the patients, dextromethorphan, and some soothing like even curcumin or colostrum tablets and chewable tablets are available, they can also be used for the soothing effect. If required, then for the fever and all, NSAIDs can be used for that. And if it is a bronchitis, then the nebulization also can be used. Plain paracetamol is most of the time it is there. With severe throat pain and all, then go for the mefenamic acid and ibuprofen. Steroids should not be used repeatedly. They have a lot of side effects. Then supplementary alternative therapies like zinc supplementation, vitamin C, some probiotics also can be used. Prevention, always use the mask, proper hygiene, clean the surfaces, disinfectants can also be used. These are very important. Immunization is also very important. Influenza, pneumococcal vaccine, H influenza B vaccines should routinely use, and the awareness is very important. And then follow the patients properly again and again after 72 hours, after 3-4 days, and reassure the people if it is a viral infection, nothing to be worried. And some of the antibiotics specifically, like amoxiclavir, amoxicillin, are very important. Then first generation cephalosporins like cefaclor, cefuroxime as a second generation one. Very severe cases, the ceftriaxone can be given. Otherwise, erythromycin, azithromycin, they are also useful depending on the chlamydia or mycoplasma infections. Epiglottitis, the cefuroxime, ceftriaxone, cefotaxime are used. And in pertussis, clarithromycin, erythromycin is a very good drug of choice. Some cases, azithromycin. Acute bacterial rhinosinusitis, amoxicillin, doxycycline, if it is a reaction of our penicillin allergy. So that way, we have to select the things and to give a message like prevention is always better. So the vaccination awareness should be there about the influenza. Even as I mentioned, the RSV vaccine also will be coming in India to prevent the bronchiolitis, severe infections, and early management. So always the parents' awareness should be there that each and every time the infection can be different. So they should approach their regular doctor and check always rather than giving us self medications, because in India self medication is very high and people use so many antibiotics and all. So they should not be given. Rather than that, the patient should be each and every time they should approach to the doctor. The doctor will decide like which to be medicines to be given. Self antibiotics and self NSAIDs and all will also cause the problems. So that awareness should be brought into the community. And then the hygiene is always important. Suppose the child is having or any adult with a upper respiratory infection, he should himself use the mask not to spread to the community. And that again causes a problem. Then underlying any, suppose repeated infections are there, always look for the cause. Immunodeficiency is commonest is the allergy, Th2 inflammation. Treat that also so that the repeated infections will not be there. And treating the root cause, the patient will not require a repeated oral and parenteral antibiotics or steroids. And we can prevent the cellulitis, ophthalmic involvement, ear problems, sinusitis. Again, we can prevent the acute emergencies, asthma exacerbations also can be reduced, as well as the abscesses and secondary otitis media leading to the ear problems or pneumonias, such type of things, septicemias. So that awareness is very important. So thank you. Thanks again for that. And we will have a time for the discussions.
Thank you so much, sir, for your wonderful presentation. We do have some question if you like to take that up.
Yes, please.
So,
Sure.
sir, the first question is, are there any emerging trends in the prevalence of specific respiratory viruses?
Yes, actually, post COVID, a lot of things have changed. So, a lot of viruses have been, uh, we are seeing a lot of invasive viruses. And and traditionally also RSV, parainfluenza viruses are very common, influenza. And specifically the allergic people, we are seeing these pneumococcal variants, which are having a lot of problems. So there, depending on that, as a preventive strategies, this Pneumo 23 vaccine is very useful above 5 years children's, which or even adults also. So now the concept of adolescent and adult vaccination also come in India. So those adults or adolescents which have repeated infections or underlying allergy and all, or any of the immunodeficiency syndromes or something, then this Pneumo 23 vaccine every 5 years should be given. Influenza vaccine every year should be given. And then depending on the season, some of the patients should be prepared for the immunomodulatory medications, like as I mentioned, the traditionally the curcumin, then colostrum also can be used in these patients. Some respiratory probiotics are there. They can also be used as an add-on therapy along with the specific antibiotics or antiviral medications. So such type of therapies should be utilized in our practices. So even we are finding nowadays a lot of some bacterial sinusitis, protracted bacterial bronchitis, where the clarithromycin is very useful in refractory cases. So we have to investigate the patients, then only we will know that.
Yes, sir. So there is another question. When is hospitalization necessary for severe respiratory infection in children?
Most important is that when the patient's very high grade fever, which is not responding to the usual conservative management with some amoxicillin or something, and if the child is not eating properly, dehydration signs are there, then that is where we have to admit the patients. Or suspected significant septicemia like pictures, where the blood pressure is also affected. Or when there is a cellulitis, cavernous sinusitis, then we should not waste the time. We have to admit the patient, we have to give the parenteral antibiotics to prevent the complications. Significant otitis media with the oral antibiotics and all, the patient is not responding. Significant vomiting, like systemic signs or irritation of the meningeal like pictures, meningitis like picture is there, then we have to investigate the further. We have to admit these patients. Or where there is a respiratory distress and pneumonia like symptoms are happening, and the patient may go into significant respiratory distress, then admit, like depending on the age group, the respiratory rate above 40, above 50, above 60, and accordingly you have to admit the patient and investigate further and give the parenteral antibiotics.
So the next question from our audience is, what diagnostic tools are available for identifying the causative agent of upper respiratory infection?
Very good question, actually. Most of the patients, they respond to the symptomatic medications. Very few people require a proper diagnosis. Suppose we are suspecting a very significant bacterial infection, and then the throat swab also can be taken. Even the throat swab PCR analysis also can be done. Where there is a significant bacteremia, septicemia, the blood culture also can be done. Then depending on the which organ involvement, even otitis and all, outside specific small devices are there, and they are kept over there, and through that one only the culture, the first is taken and checked it, and then only if it is a serous, no antibiotics. If it is a bacterial first like and the organisms are shown, then the antibiotics are given in the otitis also. So again, anterior rhinoscopy, as I mentioned, significant sinusitis if it is not resolving. Nowadays, endoscopic, very small fiber optic, the specific culture also can be obtained. We can visualize also that and we can treat accordingly. So depending on that, and when, as I mentioned, if there is a retropharyngeal abscess or something complications, lateral X-ray, epiglottitis also, depending on that, the lateral X-ray also can be done. If suspected pneumonia, then X-ray chest also should be done. So these investigations are also nowadays available. These all PCR technologies and all. We can identify the specific any viruses or bacteria are there, and cultures also can be done. When the blood culture and the that mucus or throat swab cultures also can be done.
So there's one last question from our audience. What are the
Mhm.
most effective ways to alleviate symptoms in pediatric patient with upper respiratory infections?
See, symptomatic management first 3 days. So fever is important, so antipyretics. Then localized, suppose there is an acute congestion, even the normal steam inhalation is also very useful. Then depending on that, the soothing, as I mentioned, the curcumin and colostrum, these I am using in my practice and I have found very good results. Then supportive, like some probiotics also used nowadays. Then some traditional immunomodulatory medications also there, oral can be given. If it is a cold, if it is a rhinorrhea, there is no need to give anything. But if it is a blocked nose and if it is disturbing, Then saline, nasal saline drops or douchings are also available. Or if it is significant blockers, nose and all, it is affecting the sleep, then oral antihistaminics can be given, safer one, second or third generation one. If it is a cough which is irritating to the family, it is disturbing the sleep and all, then bromhexin, dextromethorphan, ammonium chloride like uh, cough syrups are also available, which can also be given depending on the situation. If you involved with the laryngotracheoitis or bronchitis, then levosalbutamol, salbutamol syrups are also available, nebulization is also available depending on the situation. If it is the otitis, pain and all, then or bacterial sinusitis, then antibiotic along with that oral NSAIDs also can be used in these patients. So depending on the situation, we have to treat it. But most of the patient is common antibiotic, anti-cold preparations, or anti-cough medications. If antitussives in upper airway, we can give for symptomatic relief. Very few people require actual antibiotics or low respiratory involvement, then nebulization and all in upper respiratory infections.
Thank you so much, sir, for your wonderful presentation as well as answering all our questions, sir. So that's all from our audience, sir. And before concluding today's session, sir, any last remark from you?
Actually, even like I mentioned in my talk, the post-streptococcal infections and antigen formations. In India, we have seen a lot of cases. In 2014, I presented a paper in Arizona International Conference where asymptomatic rheumatic fever, 120 cases, where these people these children used to have repeated respiratory, upper respiratory infection with streptococci. And the post-streptococcal glomerulonephritis, post-streptococcal rheumatic fever is very common in Indian scenario. So it should not also be taken casually. Each and every time the patient should be taken to the doctor. Doctor should examine properly, and the self-medication should be avoided. So that this rheumatic fever is still very common in India, and this is because of the upper respiratory infections only post-streptococcal. So again, the community, the vaccination to prevent these complications. So influenza vaccines, pneumococcal vaccine, influenza B vaccination should be routinely implemented. Adolescents and adults also, depending on the underlying primary allergy or other complications like primary immunodeficiencies and all. The other vaccination, these flu or pneumococci in adolescent adults also should be given. And that way, that awareness, if it brings, we can prevent a lot of complications. And most important is that the pollution is very important for all these refractory infections. So the pollution should be brought down, indoor or outdoor pollution also, passive smokings and all. So the parents, grandparents also should awareness. Burning of the bio waste fossils should be also prevented. Use of bicycles more than the vehicles, vehicular exhaust, the construction dust. They are also very important. And the pesticide use and all, changing the genetics of the people and causing more infections. So the lifestyle modifications and the environmental modifications to the community, plantations and all is very important for the long-term purpose.
Thank you so much, sir, for joining us today. And with your permission, sir, I would like to conclude today's session. Thank
Yeah,
you.
thank you.